Well, thanks to everybody getting here on a foggy Saturday morning. It's really a pleasure to introduce Dr. Komrokji. He was at UC when we were at UC back a long time ago. He's still a referral source for a lot of us in Cincinnati. He took care of a good friend of mine for 2 decades, and just an outstanding physician. He's internationally recognized for myeloid neoplasms. He's been critically involved in clinical trials, bringing luspatercept and pacritinib to the market. He's referenced and authored over 380 peer-reviewed journals, and he's on the board for the NCCN and NHLBI. Let's welcome Dr. Komrokji.
Good morning, and thank you. It's really a pleasure to be in Cincinnati always. And Dr. Jazzy was my mentor. He took chance on me and hired me out of my fellowship. So I owe him a lot. And it's really a pleasure to be with colleagues. We actually still share patients together. And I was telling everybody last night, I still ship on dry ice Grater's ice cream to Tampa from Cincinnati. So I think I'm still in heart here. So Dr. Jazzy asked me to talk about heme malignancies. And I was like, it's hard to cover them in an hour, so how about I talk about myeloid? But the real reason I really don't know anything about myeloma or lymphoma anymore, like I just do myeloid diseases. But there is plenty of things happening that hopefully you'll find helpful. So, and in reality, many of those data were presented at ASCO and EHA at the same time, so I'll be using some slides from each, but they were all presented at ASCO at some point. Those are my conflict of interest disclosures. And I'll start with myeloproliferative neoplasms because this year at ASCO in the plenary session, there was the study on rusfertide for the first time having actually a myeloid probably at a plenary session at ASCO, and particularly in P-Vera. But I think the importance of this, that this is the first-in-class hepcidin mimetic in phase 3 trial that hopefully will be available for our patients next year. So traditionally, obviously, the treatment of P-Vera, like we divide patients into a lower risk or high risk based on age and prior clotting events. And if they are low risk, historically we did baby aspirin and phlebotomy. The guidelines now endorse actually using of raw PEG or pegylated interferon. In the higher risk patients, whether if they had an event or they are above age of 60, we always need cytoreductive therapy, hydria or raw PEG. But there are many patients that their disease is not controlled, even with those treatments, still need phlebotomies or are very symptomatic. So, rusfertide is a hepcidin mimetic. So hepcidin is a master regulator of the iron that regulates the iron absorption from the gut, the iron flow to the bone marrow. And in P-Vera patients, it's slow, so the iron is constantly flowing into the bone marrow. And a hepcidin mimetic will, adjust that or regulate that and prevent the iron free flow to the bone marrow and restore the iron balance. So the study was a phase 3. Patients were randomized between rusfertide and what's considered a standard of care and for 32 weeks with the primary endpoint looking at elimination of phlebotomies. And then there was an extension part. Patients had to have some baseline of requiring regular phlebotomies or frequent phlebotomies, and they could have been on other treatments. So those patients could have been on hydria or raw PEG, but their disease is not controlled. And the primary endpoint was, as I mentioned, that not needing any phlebotomies or not being even phlebotomy eligible with some secondary endpoints. And those were the baseline characteristics. They were balanced. I think the patients that were on rusfertide actually were needing more often phlebotomies. And as I mentioned, almost half of the patients were on other therapies, mostly hydria, but then also interferon, and a handful of patients on ruxolitinib as well. And obviously, the study met the primary endpoint where almost 77% of the patients did not need any phlebotomy on the rusfertide. It's a subcutaneous injection once weekly compared to the placebo. And when we looked at subset analysis in every subset, we saw the advantage, whether frequency of phlebotomy, other treatments, etc. And when we look at the symptom improvement, also those patients had a symptom improvement measured by this total symptom score that's widely adopted in patients with MPN. So the bottom line, patients were not needing phlebotomies and they were feeling way better, partly because it reverses the iron deficiency in those patients. And in general, very well tolerated, some injection site reaction, some anemia, but in general, very low discontinuation rate. So we are waiting for the FDA approval next year. I think this is going to be an adjunctive therapy to what we have for patients that are requiring phlebotomies. The benefit is really it eliminates phlebotomies and patients feel way better in terms of symptoms. We don't have long-term data. Is this going to prevent thrombosis, clotting? It's counterintuitive maybe because like if we are controlling the hematocrit, it will, but we don't have the long-term data. So it's going to be adjunctive therapy, but it's the first in class, and I think that's why it got a plenary session at ASCO. The other abstract that was presented oral at ASCO is ROPEG interferon in ET, and again, we are awaiting the FDA approval, hopefully before, early next year or for the end of the year. So ROPEG is a monoisomer of the interferon that's pegylated that can be given in longer duration. It's approved and used by in patients with P. vera. So this study, we looked at patients with ET. And obviously for ET, we still manage the patients similar to PV. If they are above age of 60 or had an event, they need cytoreductive therapy. There is some shift based on the driver mutation. So if patients have a calreticulin mutation, they may not necessarily always need a cytoreductive therapy. But many patients cannot tolerate hydria, or we maximize the dose and we are not able to control their counts. And there is tons of data on interferon over many decades in patients with ET, but we don't have an approval actually. So the study randomized patients that were resistant or intolerant to hydria between, ROPEG and anagrelide, which has been used as second line. I'm not a big fan historically of anagrelide. I tell my fellows never write anagrelide because it really doesn't help much the patients. They get side effects. Even data from maybe 20 years ago in a New England paper showed that it was not better than hydria controlling the clotting, but it was the control arm. And it's used as second line because that's the only probably option. JAK2 inhibitors have really not shown role in the ET patients. And obviously the primary study was a modified response, but having basically a complete hematological response, no disease progression, and no symptoms. And secondary endpoints, they looked also at molecular responses. And those were the baseline characteristics. Majority of the patients were JAK2 mutant. Typically, it's like 50% are JAK2 mutant, so that was a little bit more enriched, because historically we know also we get more molecular responses with interferon in JAK2. And the study obviously met the endpoint where almost 42% of the patients, achieved a complete response by the ALN criteria. And what we also saw, confirming the signal we see in patients with P. vera, that we see reduction in the allele burden of the mutation, so suggesting that this is disease modifying. On the left shown is the JAK2. Historically, we didn't think that interferons will induce response in patients with calreticulin, but in a handful of patients we are seeing that. The data from PV, actually 20% of the patients, so 1 out of 5 may become molecularly undetectable, that can enjoy at least a drug holiday or or permanent discontinuation. So this is the first we see in ET. Actually, there is also data showing that those responses translated to symptom improvement and reduction in clotting events. So when you look at the major thrombotic events, they were around 1% compared to 10%. The patients on anagrelide, there was a signal that they had actually more myelofibrosis, clonal evolution. So I think this emphasizes this notion that anagrelide is probably not a good choice. It always makes the physician feel better because we are lowering the platelets, but we are probably not doing much service for the patient. So I think this will lead to the approval as a second line, and hopefully it will be helpful for our patients. We've used interferon for many decades, but we didn't have a label or approval. There was not much data updates on myelofibrosis at ASCO, but this is just like a schema of a recent paper that kind of talk about how to use the JAK2 inhibitors, because we have now 4 JAK2 inhibitors in myelofibrosis: ruxolitinib, fedratinib, pacritinib, and momelotinib. And they are all helpful for patients with constitutional symptoms, splenomegaly. If the patient problem is only cytopenia, those drugs will not help the cytopenia. But now we pick based on the concomitant cytopenia. So if somebody have proliferative disease, they get ruxolitinib, second line fedratinib. If patients are anemic, we go for momelotinib. If patients are thrombocytopenic, we go for pacritinib. And we do circulate those treatments sometimes once patients had failure of a therapy. But at least we have good choices to pick from for that subset of patients. All right, so moving to MDS, obviously lower risk MDS had approval of 2 drugs and expansion of the label, which is luspatercept, that's almost replacing erythroid stimulating agents now, and emtelestat, which is the first-in-class telomerase inhibitor to be approved in patients with lower risk MDS. So now we are moving from ESAs. I think in patients with ring sideroblast positive, luspatercept had become the standard. In patients that are RS negative, we still could argue that there could be a role of ESA, but the landscape is changing, and we've got 2 drugs approved, and they were the first 2 drugs to be approved in MDS over the past probably a decade or more. In the higher risk, we still struggle. Obviously, allogeneic stem cell transplant is our only curative option. We try to get patients to transplant. We are transplanting today to age of like 75 without even thinking. We transplant even up to 80 at our center if patients are functional and in good shape. But we've not made more progress over the hypomethylating agents. There had been several trials. I think, and I'll show some data from this Verona trial on the venetoclax, I think there is still going to be some role for those patients. And TP53 myeloid neoplasm in general, whether we are calling it MDS, AML, or MPN, if patients have a multi-hit or what we call a biallelic TP53, those diseases are probably indistinguishable in the outcome, poor outcome, and a huge unmet need. And we're actually seeing more and more of those as we successfully treat solid tumors and patients are living longer, myeloma, lymphoma. We are seeing a lot of the therapy-related MDS, which unfortunately are highly enriched in those P53. I was talking to the myeloma folks recently, and I was like, I think maybe therapy-related MDS is becoming the #1 cause of mortality in myeloma patients because they are living long enough that we are seeing a lot of those patients coming to our clinic with therapy-related MDS. So in lower risk MDS, luspatercept, this data was presented both at ASCO and ESA, sorry. And it's really update on the luspatercept. Luspatercept is a fusion trap protein that neutralizes TGF-beta ligands, releasing the terminal block on erythroid differentiation. And they call them erythroid maturating agents. They got approved originally based on a study called the Medalist in patients after erythroid stimulating agents failure. So patients would have had erythropoietin, did not respond, they will go on luspatercept. That was for a subset of patients called MDS with ring sideroblast. Now we call them SF3B1, and that got the approval. This COMMAND study tried to move the treatment up front. So it's taking all lower risk MDS patients that are needing transfusion, randomizing them between luspatercept and erythropoietin, looking at transfusion independence and hemoglobin increase. And the study was highly enriched still with those patients with SF3B1. So those patients that were RS positive were majority. Only 49 and 50 patients on each arm respectively were RS negative, but it was in all comers. And obviously, what we saw at ASCO, that we are now seeing a survival advantage. This was a secondary analysis that was not powered as a primary endpoint. But at the mark of 2 or 3 years, we are starting to see the separation in the curves for survival. And this is the first time in MDS lower risk, we show if a treatment have better erythroid responses or hematological responses, that it can translate to survival advantage. Those drugs have also some anti-inflammatory effect. So there is a question also, maybe it's not just improving the anemia. And the reason we see the survival curves splitting at 3 years and after is probably expected because once patients with lower risk MDS become transfusion dependent, their average survival is 40 to 50 months. So at the 3 years mark is where we really expect to see the survival difference for those patients. So it's exciting to see that the responses are durable. And we see that both in high transfusion and low transfusion burden in patients with ring sideroblast. I think the data are really mostly speaking of ring sideroblast. The subset of patients with RS negative is smaller, but nonetheless included. So this is changing the practice that luspatercept now is becoming upfront therapy, particularly again in patients with ring sideroblasts positive. And for the first time as a proof of principle in the field, we are showing that a treatment that yields higher responses may translate to a survival advantage. The other drug that was approved in lower risk MDS is emtelestat. So this is a telomerase inhibitor taking advantage that telomerase activity is increased in MDS cells and the telomere length is short. The study that led to the approval is called the IMerge. So it's lower risk patients. after erythroid-stimulating agents failure, and they were randomized between that and placebo, and the study showed almost a 40% transfusion independency. Some of them are durable. The magnitude of hemoglobin increase is actually probably next to lenalidomide in MDS, where patients, if they are responding, their hemoglobin will go by 3 to 4 grams, and some of the patients will have cytogenetic responses or reduction in the clone size, suggesting it could be disease-modifying. The main issue is that it does cause grade 3 and 4 thrombocytopenia and neutropenia in almost more than half of the patients. The clinical infection rate or febrile neutropenia was low, but nonetheless, it's myelosuppressive, so it's not going to be our first option. It's going to be always after ESA or EMA. At ASCO and EHA, we presented data on the left side showing the RS negative group, where I showed you even with luspatercept, those patients actually don't respond as well. And 1/3 of the patients with the RS negative will become transfusion independent. On the right, also looking at patients based on their endogenous serum EPO level. And this is now endorsed in the NCCN guidelines. If patients' endogenous serum EPO level is above 500, they are unlikely to respond to erythroid-stimulating agents or luspatercept. It's a smaller subset of the patients up front, it's around 10%, but the guidelines say go to emtelostat or hypomethylating agents sometimes, and this is some of the data supporting that NCCN guideline recommendation, that in patients with EPO above 500, the responses to emtelostat were the same. And the other question we looked at is basically, since the landscape is changing, now patients are not going to be getting ESA up front. They're going to be getting luspatercept. How does emtelostat work after luspatercept? And the answer, we still see the responses in the range of 30%. Mechanistically, there should be no interaction between those two drugs. Now, in the higher risk, as I mentioned, we've not made really much progress. We've had 17 trials that unfortunately, 17 randomized clinical trials in higher risk MDS that have not shown improvement over, hypomethylating agents, and we keep trying in that area. I think some of it is really our fault in the design of studies, that we are lumping all those patients, sometimes excluding patients going to transplant. All the studies gets enriched with patients with TP53. So with every study we say we learned the lesson, but then we repeat the mistake again. But the Verona was the last one, and what everybody was hoping for. Obviously, venetoclax is approved for patients with acute myeloid leukemia, and we've been using it liberally, I would say, in patients with higher risk MDS, but this was the randomized clinical trial. It was presented at SOHO, actually, after ASCO, and this is like the top-line results. So those patients were higher risk. They randomized between AZA versus AZA venetoclax. The dosing of venetoclax in MDS is 2 weeks, while in AML, at least for the first cycle, we do 3 to 4 weeks. And unfortunately, obviously, the study was enriched with TP53, again, 1/4 of the patients. But unfortunately, the study did not show a survival advantage over azacitidine. The curves were like superimposed. And even the complete response rates, where we think that usually will translate to a better signal, was almost identical, 20 and 18%. Those overall responses or MARO CRs probably do not translate to any advantage, and we've known that. What matters really is a true CR, and we can see that was not different. Obviously, there were several pitfalls in the study. In my opinion, the most important one, that when the AZA-VEN are used for AML, and the trial that led to the approval is called the VIALE. When patients had myelosuppression, we dose adjusted the venetoclax first, and then the azacitidine. In this study, the azacitidine was dose reduced first, which I, from the beginning, didn't think that this is the right thing. And when you look here, you can see that half of the patients on the AZA alone arm has the reduction in the dose of the azacitidine, which we know that the dose of azacitidine is very crucial in higher risk MDS. So there are, again, some design issues with the study. They excluded patients going to transplant or capped it to only 20% of the patients, where contrary in real life, we see the benefit is really as a bridge to transplant. So there are several pitfalls. I don't think that venetoclax is going to be dead completely in MDS. We're probably going to see more studies, and there are actually 3 other newer generation BCL2 inhibitors that are already in clinical trials in MDS. Now, finally, AML, and it's really very hard to cover all AML in 5 minutes or 10 minutes. I will focus on probably the most exciting development, which are the menin inhibitors. But this is like my own way of how I treat patients as just a starting point. Obviously, we still decide who's eligible to get intensive chemotherapy, so patients have to be fit, no major comorbidities, and a disease that have a reasonable chance of achieving a response with intensive chemotherapy. So obviously, the core binding factor AML in version 3, translocation 821, we still go with intensive chemotherapy and add gemtuzumab or oligomycin because those patients we can cure without going transplant. Addition of gemtuzumab have around 20% survival advantage, so it's very important in those patients with core binding factor. The treatment is guided all by MRD status and molecular. In patients that have NPM1, you will have 10 people that do AML and 10 different opinions about the best way to manage an NPM1. I personally think the best data are like either with intensive chemo like FLAG, IDA, or CLIA, plus VEN in patients that are eligible for intensive chemo, and that's changing, obviously. In the FLT3 AML, we have quizartinib now approved for FLT3 ITD, and particularly in younger patients, the data looks better, so we've moved to use that combination. In the TKD FLT3, we still use Mido. Patients that have secondary AML coming from MDS, particularly if they were not treated, CPX351, which is a liposomal form of RSC daunorubicin, and in the rest, we use CLIA-VEN. We still entertain transplant in most of the patients. MRD testing is reality in patients with core binding and NPM1. We act based on MRD status. If they are persistent, we are thinking taking them to transplant. If patients have a molecular relapse, we don't wait for a hematological relapse. We treat those patients. Now, in the patients that are not eligible for transplant, and in reality, a lot of patients with AML are not. So either they are frail, older, or they have a disease that will not have a chance of response. Like if I have a patient with biallelic TP53, I rarely, if ever, would be offering them intensive chemotherapy, even if they are younger, because in reality, we have better chances with less intensive chemotherapy. IDH2 NPM1 actually do very well with HMA-VEN. The IDH1 mutant, they do better with starting with an IDH1 inhibitor. In the FLT3s, we are doing triplet. The RAS mutant AMLs tend to be resistant to venetoclax, so we tend to do something like Minicla. And again, this is our own kind of almost recipe. There is some data, obviously, to support that. In TP53, there is really nothing above hypomethylating agents that have shown to be better. Even venetoclax is not associated with survival advantage. The abstracts for ASH are out, and at the plenary session of the coming ASH abstract, there will be a randomized clinical trial actually between HMA-VEN and intensive chemotherapy in patients that we call them like the gray zone, like 60 to 75. So in reality, they are fit for chemotherapy, but they can get HMA-VEN. And in practice, we've been doing that all the time. And the study actually shows that the event-free survival and the outcomes are better with HMA-VEN than even chemotherapy. So I think we're going to see less and less use of intensive chemotherapy. The caveat on the study, obviously, that majority of those patients went to transplant. So as a totality of therapy, if we're going to do a bridge of induction to transplant, HMA-VEN may actually be even better than intensive chemotherapy. But the last part, I want to focus and go quickly over the menin inhibitors because that's been the most exciting. In every meeting, ASCO, EHA, ASH, most of the presentations in MDS are about the menin inhibitors. So those can target patients with this MLL gene arrangement or KM2TA. That's around 5 to 10% of the AML patients enriched in therapy-related, and also can work in NPM1 because menin inhibitors will inhibit this interaction between the menin and the HOX/MEIS pathway that's overactivated, and that is important in both patients with KM2TA rearrangement and NPM1, and probably other subtypes, like there is rare entity called NUP98. We have the first drug approved and available now, revumenib. This is the first menin inhibitor approved. The original approval was for the KM2TA patients because those are unmet need. And a couple of weeks ago, we got also the approval for the NPM1. So the approvals are all based in patients that are relapsed refractory AML as a second line. So revumenib, based on this study, had around 20 to 30% responses. The durability of responses are still not that great with single agent with any of those 6 to 12 months, but they do serve as a bridge to transplant. Historically, obviously, those patients had 2 to 3 months survival and less than 10% chance of responding to anything. And this is the data with the revumenib in NPM1, again around 20 to 30% responses, and a bridge to transplant. And now the label got expanded 2 weeks ago, as I mentioned, for relapse refractory NPM1 patients. And we are already moving, so there is this triplet from MD Anderson called the SAVE that we are combining revumenib with oral decitabine, with oral ven, so total oral therapy. The responses go high and the CR rates go up to almost 50% when we do the combination. And the BEAT AML trial is already moving this triplet up front. Azacitidine alone in patients with KMT2A doesn't do well. Venetoclax may improve the responses a little bit, but the triplet really looks very promising where, you can see here at least the overall responses are, almost 67%. So again, we still need more data with that, but they are rapidly moving to upfront setting to triplets. There are 3 other drugs. I'll just very briefly go through them. Ziftomenib, which hopefully by the end of the month we'll hear from the FDA on the approval for the relapsed refractory NPM1. This was based on this study. Again, the theme is going to be the same, that overall we are seeing around 30% responses, complete response with those agents in patients with relapsed refractory disease. So this hopefully will be available end of the month. There are some differences between those drugs in toxicity and administration that we may start using different agents based on the toxicity profile or on the patient characteristics. The third one is called Bleximenib. This is from J&J. And again, this is the phase 2 data that showed, again, 30% almost response. But this is already in phase 3 trials in combination with intensive chemotherapy, in combination with HMA, VEN. So the similar theme. And finally, the last kid on the block is Inozamenib. This is from Sumitomo, and this is their data preliminary that was presented and updated at EHA and ASCO as well. And they are seeing 30 to 40% responses. So this is again in development. They are looking at arms for molecular relapse and different subsets. But we are already starting to see, the resistance for those drugs. So this is the work from the Memorial Group showing that we see mutations in the men early on. Actually, they can happen early within the treatment, and then the relapse happens after that. We don't know if they are going to be a class effect, that if somebody develops one of those mutations, they are going to be resistant to all of them, or that we'll start to be having the story like in CML, we look at the mutation and we tailor or change the treatments accordingly. Now, all those drugs have toxicity profile. The signature for the whole class is the differentiation syndrome. That's dropping down. I think it's not difference between the drugs, but I think we are learning better. So the Inozamenib, for example, was the last, so we see the less, differentiation syndrome, but it's a class effect. All of them will have differentiation syndrome. We are used now to differentiation syndrome with other drugs like IDH inhibitors, APL treatment. The thing peculiar about the differentiation syndrome with menin inhibitors, it happens very early sometimes and a little bit even more vague than the classical differentiation because patients usually have ARDS-like symptoms, fever, shortness of breath. With this, patients get joint pain, aches, their blasts are increasing. Originally in the studies, they were called progression. So it does have peculiar flavor of the differentiation syndrome. With revumenib, we see some QT prolongation, but we are getting better in the management. I think that's why the rate is dropping. So with that, I will stop. This is a picture 20 years ago for Dr. Jazzy that looks the same. And for me, and many of the giants really at University of Cincinnati, like Dr. Wilter and Dr. Troop, that we learn from them for every leukemia conference. So thank you very much for listening.
Rami, great talk. Thank you so much. And let me ask you your prediction on next major breakthroughs. And I think it's remarkable. If you think about certain elements of technology, Wright brothers on the moon in 60 years and 50 more years and incremental improvements. New York City to Cincinnati in the 1960s, an hour-and-a-half flight. Now, about an hour-and-a-half flight, except for longer lines. So incremental improvements. But in cancer, cytotoxic chemotherapy, 3 and 7, that's over 40 years old. CHOP's over 40 years old. R-CHOP's over 30 years old. Immunotherapy's been a home run for a lot of people. But what do you see as the next big improvement?
Right. I think to your point, probably in the myeloid is going away from the intensive chemotherapy. I think we are on the edge of that probably we'll see this soon, that we are not going to be using intensive chemotherapy, and we will go for less and less intensive therapies. I think within even the coming 5 years, we will see like a principle of total oral therapy for those patients at home. We are not replacing the transplants yet. Myeloid diseases had been a challenge to break into with the immune therapies. So far, we've not had any successful CAR T or bispecific that's really, because part of the problem in the myeloid, at least different from lymphoma or myeloma, the immune system is totally exhausted in those patients. We cannot depend on their immune system. So we'll have to do something off the shelf, allo CAR Ts, or like, stuff like that. But I can see in the near future that we will not be using chemotherapy. We were talking last night that at one point in the history, they will say those savages used to use chemotherapy for treatment of cancers. So we are going away from that. Obviously, and it's going to become targeted therapy. It's going to not become like AML. It's going to be what's the mutation or what's the combination of the mutations. We go after that. The real challenge that I would like really to see any progress in is this TP53 mutant myeloid neoplasm, because it's a huge unmet need. At this point, it's like 30% of our practice. We are seeing patients after myeloma, lymphoma, solid tumors coming with those mutations, and we really have nothing to offer them. There are several trials trying to look at drugs that can restore the wild function of the TP53, but it's really that it's the most challenging because even transplant doesn't work in that setting. But I think the first step is going to be that we're going to go away from the intensive chemotherapy, hopefully for the good.
I have a question. Myelofibrosis. Traditionally, ruxolitinib and so forth have been approved on spleen size and symptom control. Are we finally past that? We're going to start looking at disease modification.
Right, so that's a very good question. It's like a lot of debate in the field, like are we moving from just symptom improvement and spleen? To date, we have not completely, but I think all the studies are looking at different things. Now, obviously, historically now that we know that patients do drive survival advantage from those agents, that spleen reduction does correlate with survival and symptom improvement. I always say, like, I don't start a patient on those therapies saying they are going to drive survival advantage, but if patient is symptomatic with spleen and constitutional symptoms and they get a JAK2 inhibitor, I think we have enough evidence in the literature showing we have survival advantage. But now the talk in the field is exactly what you are saying. It's like, should we move beyond just symptom improvement? And all the newer trials are trying to look at that in combinations to see are we, the problem is also sometimes that the survival is relatively longer than AML, MDS, and myelofibrosis, so it becomes challenging to do a trial. So what could be a good surrogate marker for survival benefit? Fibrosis historically had not correlated very well. None of those drugs so far had been reducing the JAK2 allele burden, but there are some attempts. In every meeting they are talking about should we move beyond those. I don't think we've moved completely yet.
I always think it's interesting too. There are hematologists that take care of myelofibrosis, but oh my God, the platelets are 50,000, let's stop the drug. I've never been able to understand that. We all treat leukemia where, okay, it's 20,000, or they're an outpatient, we don't worry about it. Why is the FDA so focused on platelet count and we can't just kind of push through it?
Right, I know, because I think that the worry was about the bleeding, and historically that's what we a little bit struggled with in the MDS and myeloproliferative neoplasm. They are not looked at as serious diseases as like AML, although when you show the data, sometimes subsets of MDS, AML actually, or myelofibrosis have worse outcome than AML. So historically, the FDA is way more cautious about the benefit risk and kind of balance in those diseases. The risk of bleeding does increase, but to your point, like if we have patients that are very symptomatic, like I'm usually very comfortable unless the platelets are dropping below 30 or 20, or the patients had history of bleed. The pacritinib, the FDA really restricted the label because they say if the platelets are less than 50, that's the unmet need, that's the only way we'll give you. Their data actually is very good up to 100, but then they still restricted them. And I think it's just like this benefit risk analysis in the mind. And to your first point, that the FDA looks at all those treatments as palliative. So they say this is not a treatment for survival. Those are symptom improvement treatment. I'm not going to take risk and allow people to push the dosing.
So I'm going to try to ask you the impossible question. Dr. Teferi gave a talk at an Indie Heme review I'm sure you've heard the talk.
Yes.
Where he shows the list of 25 new drugs that have come out from myelofibrosis, and every one of them is not showing an overall survival benefit. And he waves his hand saying, why are we treating anything other than symptom management? Ops, you presented some very exciting data, especially with rusfertide. If you were wearing your What Would Teferi Do wristband, how would you be using that drug if it was approved? I mean, do you think it's going to be clinically important, or is this one of those where you're treating yourself rather than the patient?
Yeah. So I think obviously Dr. Tafiri is a giant in the field, and like I've learned reading his books when I was even a student, but sometimes we disagree a little bit. I think it's a little bit more green, and we are making progress a little bit more than he usually says. But rusfertide is, to your point, it's interesting. I don't think this is a drug that's going to be a treatment for survival or changing the natural history of the disease. I think interferon-based therapy is, but rusfertide is going to be adjunct therapy. It's going to be for patients that have really very proliferative disease, that we are not able to control them, some patients that may not be able to take therapy. It does improve the quality of life dramatically for the patients. I honestly think it depends on how the company is going to position this drug. If they are going to position the drug at a cost of an oncology drug, it's not going to be used because, you know, it's, to your point, it's not shown to show survival. We even don't have data on the thrombosis risk. You say, yeah, like we control the hematocrit, there's going to be no thrombosis. But it's really a little bit more complicated than that. The white count, the mutation matters, all that stuff. But if it's priced and positioned as adjunct therapy for patients that we make them iron deficient and they are symptomatic and stuff, it will have a great role as adjunct therapy. I don't think this is a disease-modifying treatment that will be in the heart. But it opens the door for all this hepcidin pathway targeting. So now this is the first hepcidin mimetic. There is 2 in trials already, but there are also hepcidin antagonists in myelofibrosis for anemia and in MDS. So I think why it got a lot of press publicity is that it's the first drug targeting that class. But again, I think it's going to just be an adjunct therapy. It's not going to be a mainstay. So I'll agree with Dr. Tafiri on this one. It's not going to be improving survival.
And then I had never thought about using busulfan for MPNs just because it seemed like an old drug, but he seems to be an advocate for it.
Right.
Is this going to be a source of disagreement between you and him?
Yes.
Or okay.
I would not do that. So it's like, I think, it's like older drug. And in reality, when you look at the data, the risk of therapy-related MDS and AML is huge in those patients. And every now and then, if you really, really needed cytoreductive therapy in those diseases, cladribine is a good drug. Data comes from Dr. Tafiri, actually, that you can cytoreduce patients. And nowadays, with all those JAK2 inhibitors, and sometimes we do a little bit cytoreduction with that. But I don't remember the last time I used BU, or I would ever be gutsy to use it. So, right. I've had in the past when we had a patient that's 90-year-old, you give them one-time radioactive P32 and they are done. Their B-Vera is gone. Their risk of leukemia is almost 100%, but in 15 years. But, so. Yeah, so in myeloid, not much advancement. So obviously, we've tried different things. We tried, different targets. As I mentioned, the challenge first, the targets are not easy to identify like in myeloid or lymphoma. And the targets are expressed both in the leukemia cells and the normal cells, like CD33. So that's one challenge, is to delivering the CAR Ts to the right, cells. The other challenge that in general, T cells are completely exhausted in MDS, AML patients. They don't mount immune responses. So we are taking those cells, expanding them, but they are already dysfunctional. So it's been very tough, and I think it has to be an allo, approach or NK-based. We have bispecifics in trials. Actually, in myeloproliferative diseases, this calreticulin, which is the second most common, is immunogenic, so the immune system can recognize it. And we've done monoclonal antibodies. We have a bispecific now. We've done an mRNA vaccine, and there is talk about a CAR T in that population. So it will be selected in certain populations. They are all in trial. The first look on the bispecifics in the calreticulin mutant MPNs, that you see eradication of the clone, but it's very, very early phase 1 trials. It's challenging, and I don't know if we will be other than really, the only thing I can think of is allo CAR Ts. Now we are dealing a lot with the CAR Ts from the myeloma, lymphoma, even in the myeloid side. So we actually like work very closely with the lymphoma and myeloma teams. We sequence those patients before going to CAR Ts, because those patients in general are heavily treated for lymphoma or myeloma. So the incidence of this CHIP mutation, clonal hematopoiesis, is very high in those patients. And they get the CAR Ts, and like within 3 or 4 months, sometimes we see full-blown AML in those patients, that unfortunately the survival for those patients is like 6 to 9 months. I don't think the CAR Ts cause leukemias. I think the CAR Ts is like provoke a very inflammatory milieu that it leads those clones pre-existing to expand. So we are sequencing the patients, trying to see in the future, can we do some prophylactic anti-inflammatory agents or something like that. So we deal a lot in the CAR Ts with that. Even those patients that have CHIP, their cytopenias and complications post-CAR Ts are actually more. So we are also trying to look at modification. We did a project recently, even in the TIL therapies for melanomas, and those patients, if they have CHIP, their cytopenia and recovery was different. So that's where we are working in the myeloid world. In the CAR T, we're trying, more for the myeloma and lymphoma, and hopefully eventually we'll make a breakthrough in the myeloid.
We work to try and get people into the best remission as possible to go into transplant. Do you want to talk about post-transplant therapy, which is now taking hold?
Right. And that's obviously a very good question. So the question is, like, we try to get patients into remission, take them to transplant, then maintenance post-transplant, is there a role for that or not? In AML, obviously, we still require patients to be in remission. There was one study, European challenged that dogma, said you can actually take patients to transplant without salvage and they will be okay. It was heavily criticized because their conditioning was almost like a salvage. So people still require remission. In MDS, that notion has been really recently very well challenged, that you don't have to have a complete response in MDS. As long as you contain the blast below 10%, you could go. There had been several trials that, or like analyses that showed that use of response to azacitidine before transplant, downstaging even the IPSS doesn't matter. So the only time patients do worse if their disease was progressing through the treatment before the transplant in MDS. But then the maintenance is a very important issue. There are subsets, obviously, that the maintenance is probably considered standard, like a FLT3. If those patients have a detected abnormality before or after transplant, I think the role of FLT3 maintenance is pretty well established. People are looking at other subsets. If patients don't go to transplant, we do maintenance with oral azacitidine. In our practice, actually, there has not been a big study randomized showing benefit. But in higher risk subsets like TP53, we actually do maintenance, and we tell patients this is not supported by level 1 evidence, but when we look at historical cohorts, we see impact. So we do hypomethylating agents in selected higher risk. I think the menin inhibitors will be in maintenance. So I think the maintenance is important. And the other thing that relates to the maintenance is like the molecular monitoring for those patients. Like now we check for like MPM1, like MRD. If at the end of the treatment they are MRD positive, we are taking them to transplant. If after transplant, anytime I confirm that the patient was MRD negative and turned positive, we act on salvage. We don't wait for a frank relapse for those patients.
Thank you very much for an excellent talk.
Thank you very much. Thank you. A pleasure to be here. Thank you.